Once again, thank you all very much for coming and for giving me the opportunity to give this talk. I'm very excited. It's a ton of work to review the literature on this area. Here are my disclosures, and my disclaimers are as follows. I've reviewed the literature from the past year, though I included a few papers that are slightly older. This is not intended to be an all-inclusive discussion, but really a highlight of some important topics. Some of these papers are already published, others have been accepted but are publication ahead of print. And most importantly, if I didn't summarize your paper, please forgive me. There are really a lot of papers worth discussing, but I only have 20 minutes. So these, I think, are the real highlights in the changing landscape of pediatric inflammatory bowel disease. First of all, regulators, both at the FDA and at the European Medicines Association, are encouraging a transition from physician-reported activity indices, such as the PCDAI and the PUCAI, to patient-reported outcomes and also endoscopic measures of disease inflammation. They want harder endpoints. We're having introduced increasing data on therapeutic drug monitoring and also on dose escalation of biologics. We have new medicines that we're currently using off-label, but pediatric data is starting to trickle in. We have increasing recognition that psychosocial factors affect the quality of life. And of course, ever ongoing is patient interest in non-immunosuppressive therapies, including dietary changes and fecal microbial transplantation. I'm going to touch on some of these today. The regulators really fired the shot across the bow recently in this paper by Sun and Dr. Mulberg and people from the FDA, where they said the following, quote, the Pediatric Crohn's Disease Activity Index, the Adult Crohn's Disease Activity Index, and the Harvey-Bradshaw Index that have been used in Crohn's disease clinical studies lack adequate measurement properties, meaning validity, reliability, and sensitivity to change that are required to support approval of products intended to treat pediatric Crohn's. In other words, the measures, the rulers we've been using for years to track patient outcomes and to assess drug efficacy just aren't good enough anymore. And the reason why is really here, and this is a nice study by Dan Turner, who probably does more work in this area than anybody else. And what he did was he compared 4 different versions of the Pediatric Crohn's Disease Activity Index with endoscopic inflammation as well as CRP. And as you can see here, this is a marker of endoscopic disease severity. This is a marker here of the PCDI scores, and the measurements are all over the map. In other words, as I like to say, Crohn's is a sneaky disease, and you can look pretty good on the outside, but still have significant inflammation brewing on the inside. So correlation between symptoms and endoscopy at best is fair. The role of calprotectin has yet to be determined, and we need better markers and more carefully sensitive tests. So we don't want to be doing colonoscopy on our patients every 2 months or every year like we would do a CRP or a Crohn's Disease Activity Index. Are there any other non-invasive biomarkers that could be used? This is a nice study done at the Mass General by Chris Moran, Jess Kaplan, Harland Winter, that correlated the endoscopic findings to MRI findings. And what they had was 30 patients with Crohn's disease that underwent MRI within about 2 weeks of colonoscopy, and then they had blinded review scoring of the endoscopies and of the MRIs. And what they showed was that MRI strongly correlated with mucosal inflammation or healing. If you look up top with a sick colon, there's a whole lot of, thin wall here. Here there's a lot of inflammation. And what they showed is that they could identify a number of factors with MRI that are consistent with mucosal healing, including a reduction in wall thickness, reduction in hyperenhancement, reduction in hypervascularity, and decrease in bowel wall edema. So colonoscopy and MRI are probably pretty good objective markers. I certainly do use MRI more in the mid-small bowel where I can't reach the disease with the colonoscope. But the key point here is we need new clinical outcome measurements in pediatric inflammatory bowel disease, including patient-reported outcomes, quality of life measures, including school attendance. We need to validate endoscopic disease activity indices. We need more validated biomarkers. And growth, which is something we often talk about, may be useful to measure, but at least according to this paper by Dr. Sun and the regulators at the FDA, too many variables affect it: nutrition, behavior, genetics, corticosteroid use. So growth can't reliably be used as an endpoint, at least in short-term drug trials. So people are working hard at developing patient-reported outcomes that will be acceptable to the regulators. And again, Dan Turner and also Tony Otley are two of the leaders in this. They've developed some very nice ulcerative colitis patient-reported outcome, but it's still being validated. And you start with qualitative measures. You take patients and children in the room and you say, what constitutes a good day and a bad day? And then you use biostatistics to try to figure out what the most statistically significant aspects of relapse versus remission are. And it's no surprise in ulcerative colitis, but abdominal pain, rectal bleeding, stool frequency, stool consistency, and then well-being are the things that pop up in the PRO. So not too many dramatic changes here, but we're going to have tools that patients can fill out themselves, either online or perhaps in the clinic, that will be validated and accurate in the future. And I can tell you that the Crohn's one is also underway, just hasn't been published yet. Now, this is another recent study that was recently published in the Journal of Pediatrics that used actually a patient-reported outcome information system that's already been validated in adults and to a certain degree in children. This is the PROMIS score, and the PROMIS score is a widely utilized patient-reported outcome, but it's not disease-specific, it's health-specific, that measures 5 different domains, including pain interference, how much does pain interfere with your daily life, anxiety, depression, fatigue, and peer relationships. And here they used an online, actually, assessment using the CCFA Partners cohort, where people could enter this data online, give informed consent online, and they did 2 PROMIS scores, one at entry into the study and one 6 months later, and there was a strong correlation between PROMIS scores and disease activity. So again, more measures now, moving from what a physician fills out in the clinic to endoscopy and what the patient fills out. Now, one, of course, of the downsides of patient-reported outcomes, if, of course, psychological outcomes might affect the outcome measure itself. So this interesting study looked specifically at anxiety. Other studies have looked at depression. And Dr. Regatta looked at the question of, does IBD result in anxiety, or does anxiety increase the risk of an IBD flare? And they used another tool that's been validated generally called the SCARED survey. It's an anxiety measure for pediatrics. They gave it to 86 children, and what they found out was that approximately 25% of children just randomly screened in a clinic had anxiety at baseline, and this fraction of patients were more likely to experience clinical relapse, more likely to receive hospital-based interventions, including office visits, hospitalizations, procedures, and emergency department visits. And this is even after adjusting for disease activity. So I think increasingly in our clinics, we're going to start screening more for anxiety and for depression. And I know there are major initiatives through the Improved Care Now Consortium to do this. So getting away from measures, but just summarizing, the future directions in this important area include the development of a Crohn's disease patient-reported outcome, figuring out how much of an impact anxiety and depression affect patient-reported outcomes, simple and easier psychosocial screens, and one that's been used and advocated again by the Improved Care Now Network is a PHQ-9, which is only 9 questions. We're starting a PHQ-4, which is only 4 questions. And then we're going to try to correlate that with physician-reported outcomes, such as the PUCI, then maybe patient-reported outcomes, biomarkers, and other things down the road. You're also going to start seeing routine patient-reported outcome use in clinical trials, and the question is, will this be a secondary or a primary endpoint? So now we're going to move from measures, how do we measure how our patients are doing, to treatments. How should we use our treatments to try to get patients better? And again, over the last year, the literature has really suggested two major categories. One is using our old drugs better, dose escalation of biologics, therapeutic drug monitoring, and also for those patients that on infliximab that undergo surgery, there are a couple of very nice papers that suggest if you undergo surgery while on infliximab, it's probably okay, and that's good news for us. And then we're going to talk very briefly about the pediatric experience with new drugs, including vedolizumab and ustekinumab. Limited data, but I'll show you what I got. Now, this is a slightly older study. It appeared in the middle of 2015 in Gastro, but again, a very important paper, and this is the TAXIT trial. And what you need to know about this trial, this was a randomized trial of clinical dose adjustment of infliximab, basically adjustment based on symptoms, adjustment based on labs, versus level-based dose adjustment. All of these patients basically were in other studies. Most of them were on infliximab monotherapy. And basically what they looked for was a stable clinical response by week 14, and those patients that already had antibodies to infliximab were excluded. So half the group got basically adjustment if their physician thought it was appropriate, and others were dosed by a very complicated algorithm you can see over here. But basically all they did was measure levels, and then almost every infusion tweak the dose based on a level. And what's interesting about this paper is after 1 year, there was no difference in 1 year remission rates. Actually, 2/3 of both groups were actually in remission. However, the people who did the study, who are strong believers in therapeutic drug monitoring, did note there was a dose reduction in some patients, that there were fewer flares in the group that had therapeutic drug monitoring, and also they noted that 3 patients in the clinically dosed group developed antibodies, none in the therapeutic drug monitoring group. This was not statistically significant, and I don't know that we can conclusively say that low levels are immunogenic, which some people say, but at least it does raise that question. Are low levels over time or not giving enough, is that immunogenic? So moving forward, moving forward, we did a study recently, as has the Children's Hospital of Philadelphia, looking at antibodies to infliximab and infliximab levels in children with inflammatory bowel disease. So our cohort done by Dr. Zydemirsky basically was a cross-sectional cohort of 133 children currently in our infusion center. All were still receiving infliximab, and they were all in clinical remission, all doing well. But this is the red flag here. 20% of these patients had antibodies to infliximab with varying titers. And these antibodies generally correlated with lower infliximab levels, but as I mentioned, they were all asymptomatic. They had not, as of yet, developed loss of response or infusion reactions. So this raises the question that there may be a latency period between the time you get antibodies, the time your level drops, and then the time you lose response. You might be able to stay healthy for a while, even if your level's low and you have no antibodies. A different study by Dr. Stein and Baldessano looked at this issue also, and they're much more advocates of therapeutic drug monitoring and levels. And they did a prospective study of 77 children treated with infliximab, of which 38% were on immunomodulators. After 12 months, 80% remained on infliximab treatment. The others were taken off because of loss of response, anaphylaxis, or other adverse events. And what they said is a level of 9 is good, and the level below 9, basically, you may be at higher likelihood to lose response. And what was interesting here was they did not note an effect of immunomodulators on the primary outcome, which was staying on infliximab, which is in direct contrast to another study that was done through the multi-center registry that Dr. Hyams has organized. And he looked at 502 children on infliximab, followed for 5 years or more in a large multi-center registry. And he noted, quote, greater length of concomitant use of immunomodulators was associated with increased time on infliximab therapy. So again, 2 different studies, very different results. This one has long-term follow-up. I'm not sure which one to believe yet. We need more data on this topic. Now, what do you do if patients start losing response or doing other things? Well, you dose escalate, right? And you dose escalate either infliximab or adalimumab, and that really results usually in a big fight with your insurance company that pushes back. We don't want to give you more drug. There's no data. Yes, there's data. Remember this paper, to fight with your insurance company. So this was a very nice sub-analysis of the adalimumab trial that obtained the label for pediatric Crohn's disease. And the key point was, in patients that had persistently active disease, dose escalation to weekly was associated with remission rates of around 50% without an increase in adverse events. So again, a very important study arguing for dose escalation in patients that lose response and don't have antibodies. So here are the questions I have about therapeutic drug monitoring, and I still struggle with this issue. Other people have it all mapped out, but these are the questions I have. Is routine monitoring of infliximab levels and antibodies indicated? I actually believe it is, but I'm not sure about the answer to question 2, which is at what time points should we do the assays? Some people argue week 14, but then do you do it every 6 months? Do you do it annually? What assay should we use? Because there are many commercially available assays out there. Who pays for the assay? A huge issue. These are very expensive, often denied by insurance. Are low levels of infliximab really immunogenic, or does the development of antibodies reduce the levels and make the levels low? I still don't know what's chicken and what's egg here, and I don't think there's enough data to say for sure. Does combination therapy reduce the need for therapeutic drug monitoring? What about adalimumab, of course? And then how should we adjust doses? And I do want to give a shout out to this one website here called the Bridge IBD Group. This is a group of young investigators, strong advocates of therapeutic drug monitoring. It includes Marla Dubinsky, it includes Adam Shefitz and other people. And you can actually look at this algorithm and get additional information about whether or not you need to or should optimize your anti-TNF dose. So one other plug, Michael Kappelman's combined trial, I think, is going to give us a ton of information about the efficacy of combination therapy. We're going to take children starting anti-TNF with no contraindication to methotrexate use, and we're going to randomize them to either anti-TNF plus methotrexate or anti-TNF plus placebo, follow them out for 2 years, and we're going to really know whether low-dose methotrexate, which is something we commonly use in practice, is something that's going to be helpful at reducing antibody levels, preventing loss of response. So a couple other just quick hits from the literature. 2 papers looked at the impact of infliximab on surgical complications in pediatric IBD. Both somewhat underpowered, but you put them together, they're both reassuring. Neither paper found any significant increase in complications. Again, a paper from Boston Children's by Lori Zimmerman and a paper from Baylor by Dr. Kellermeyer both showed fairly similar results, suggesting you probably can do surgery safely in kids on infliximab. Moving on to our new treatments, vedolizumab, basically, I think, as you all know, if you went to this morning's session, it binds to alpha-4 beta-7 integrin. It prevents lymphocytes from getting out into the mucosa, and it's a very selective drug targeting the GI epithelium. We have pediatric data now from Dr. Namita Singh, Dr. Hyams, and Dr. Dubinsky on this. And actually, it looks to work almost as well as vedolizumab in adults, Basically, in this study, 52 children aged 7 to 17, and what you had was 30 patients with Crohn's, 22 with ulcerative colitis. And if you looked at the long-term remission rates in this group of patients, most of whom had gotten TNF, there was a 76% response rate in the UC group, 42% in the Crohn's group. Ustekinumab, much less data, just quickly. Ustekinumab blocks this antibody, which is IL-12 and 23. It blocks the cytokine, and it prevents the differentiation of T cells to Th1 cells, and therefore it hits the Crohn's pathway. Very limited data in pediatrics. Here's 4 patients on ustekinumab. 2 got better, 2 didn't. Why am I putting this paper out of 4 patients? Again, just in case you need it to justify its use to insurance companies for off-label use. And I do have to emphasize, off-label does not necessarily mean experimental. I always say this. The FDA says a physician may prescribe a drug for uses or in treatment regimens or patient populations that are not included in approved labeling. Unapproved, or more precisely, unlabeled uses may be appropriate and rational in certain circumstances. And the AAP says the term off-label does not imply an improper or investigational use. Finally, one last study for people who are very interested in diet, which I think we all are, but it was an internet-based anonymous survey of people who use the specific carbohydrate diet to treat their IBD, emphasizing variable response and remission rates, even subjectively with this diet. And a lot of people stop the diet because the weight loss too difficult, ineffective. People who don't want medications are more likely to report a response. So in summary, there's a lot more work that needs to be done. We need to develop and validate activity indices. We need more objective measures in assessing drug efficacy. We need more data on therapeutic drug monitoring. We need larger randomized control studies like COMBINE to get pediatric labeling of some of our treatments. And we need more studies of non-immunosuppressive treatments with more rigorous endpoints. Thank you very much.